Good morning and welcome, everybody. Welcome to the Retired Living True series. For those who don't know me, my name's Brett Janelle and I'm your host today. I see a number of familiar faces and a number of new faces. And today's topic is the truth about healthcare for seniors. One size doesn't fit all. So who intimately knows how our healthcare system here works? Who knows it back to front? Okay. Who thinks there's so much to learn it's really kind of overwhelming? Yeah, most of us. Who hasn't been to see a doctor in like 10 or more years? Anybody? A few of us? Yeah, thank you for being honest. Yeah. So it is a very complicated topic. And where's my little slide? And in preparing for this, I was just pulling up some statistics that I came across from a colleague, and I thought this was really interesting. There are 60,000 ways our organ systems within our body can fail. 60,000 ways we can fail. There are over 6,000 prescription drugs available on the market today to help us in so many different ways. Oops. And over 4,000 medical and surgical procedures available. So if we kind of multiply those all out, there's millions of different combinations and permutations of things we could possibly need or be on. So in order to try to help us understand our medical system here a little bit better, I have two fantastic panelists that I'm so excited about to have the opportunity to introduce you to today that are going to come up and join me and help us learn a little bit more about it. And actually, can my panelists come up and join me now? And just while they're doing so, I just want to give gratitude to a couple of people that made this possible for me. I don't know if Jamie Ubaldi's in the room from Northern Nevada Health Systems. You in here, Jamie? So Jamie helped me have Dr. Sanford join us today. Welcome, Dr. Sanford. And then I asked also a couple of other of our education partners, Tammy Malley from Centerwell Health, Amanda Reed from Gentiva Hospice, and also Gary Eldex. I don't know if Gary's here. No, he's not today, from Sanford Center for Aging. And one name came up from all three of those, and that's Dr. Phillips, who's joining us as well. So we have a wealth of knowledge between these two doctors joining us today, and I'm so excited to have you both here. Welcome. Yeah. So if I could start with you, Dr. Sanford, could you just introduce yourself and just tell the audience a little bit about your background and why you're here on the panel today? I apologize. I told you I would have that turned on.
Right. I think it's working. So my name's Dr. Andrea Sanford, and I actually grew up here in Reno, Nevada, and I went to UNR and medical school here and completed my family medicine residency here as well. And so I finished my residency just this past summer, and I've been serving as a primary care doctor with Northern Nevada for the past about 4 months. And so as a primary care doctor, I see all ages from newborns all the way up through the elderly. And so it's a very fun mix of patients, and we see older patients all the time, every day. And so with doing all of my training here in Reno, I know a lot about all of the different hospitals in Reno. I trained in the VA, Renown, St. Mary's. I basically trained everywhere but where I'm currently working at Northern Nevada. But yeah, I'm very excited to be here today.
Thank you so much. Dr. Phillips.
Good morning. I'm Steve Phillips. I'm internist geriatrician. I see a lot of familiar faces. May not remember your names, but I do see some familiar faces. I've been here since 1992. I was the first licensed geriatrician fellowship trained in the state of Nevada. I was big fish in a little pond.
Could you just hold that a little closer?
Compared to California. So I have a extensive background in local, state, national policymaking, delivery of care. So I'm really excited to be here, and I'm semi-retired now. I actually officially sold my practice, Geriatric Specialty Care of Nevada, in December, and will be remaining as a consultant for the rest of the year. So thank you.
Wonderful. So I'd like to start off by asking you, maybe Dr. Sanford, just to help us understand our medical system when we need help, where we go. As we polled, there's some people who haven't been to see the doctor in a long, long time. And there's others who I know spend a lot of time scheduling their calendar around our seminars and their doctor appointments. Yeah. So I think in everybody's handout, you should have a page that kind of talks about the different healthcare options that we have in the community. And I think I have a slide. Yeah, you should have a page that looks kind of like this. Did you want me to grab you guys copies at all, or you good to? Let me just grab. Oh, maybe these two. So what's our first point of contact for those who haven't been to see a doctor in a long time, if ever, in terms of where do we kind of start? And then if you could kind of touch on what's important that you feel the audience should know.
All right. So I think that's a great question because sometimes when it comes to our healthcare, it can be very overwhelming to get started and where to get started. But I think the first step is trying to find what we call PCP, which stands for primary care physician, that we enjoy, that we can talk to, and that we can trust. I think it's very important. And there are many different types of primary care doctors. As we see, there's a whole little paragraph with multiple bullets of different types of PCPs. And the first thing is regular medicine. So that is a primary care doctor that works typically for a group. You use your insurance to go there, and they see all ages. There's also something called direct primary care, or some people call it like concierge medicine. That's a little bit more specific. You tend to have a little bit more access to those doctors, longer appointments, that sort of a thing. And that tends to work a little bit less with insurance and more with things like monthly fees or yearly fees, things like that. So if you want really good care, that you talk to your doctor all the time and you have direct access to them, that's an option for you as well, but that tends to be a little bit more expensive. There's also some clinics starting to specialize in specific age populations and specific medicines, that sort of a thing. And then...
Oh, did we die? What was the one? Thank you.
Thank you. Along with that goes with when does telehealth come into play. So telehealth can be very beneficial, especially when it's hard to get out in the snow or get out and leave our homes. But the real thing is when is that appropriate? So things like follow-up appointments for chronic health conditions, like your blood pressure follow-up, certain diabetes follow-up if you've gotten your labs, basic things like that can be done over telehealth. More acute things like if you have new swelling in your legs, a new rash, anything that the doctor really needs to see and evaluate in person or do an exam, like new abdominal pain where an abdominal exam would be really important, those tend to be much less beneficial in telehealth. So those things going in to see a doctor could be much more helpful. And then it kind of gets into what's the difference between an MD, a DO, a PA, nurse practitioner, RN. And that can be kind of overwhelming as well. MDs and DOs are very, very similar. So those are doctors that went through medical school, went to residency, have been very, very well trained, whereas PAs and nurse practitioners and RNs, they do a little bit less training. So that's kind of the broad description of what the difference between those are. And so as things get more complicated as we get older, some patients like to see MDs or DOs instead of some of the alternatives because of the training level differences. And then a little bit off of that, when do we go to urgent care? Urgent care is great, but I recommend to have a PCP as well. So sometimes your primary care physician has a blocked schedule for the day. You have a cold, you have some shortness of breath, maybe a COPD exacerbation, and you can't get in with your primary care doctor. Urgent care is a great time to utilize that. But I would urge to not only use that and not have a primary care doctor. So I would urge to use that in the other moments. And then a question of when to go to the ER versus urgent care often comes up. First of all, if you think you're having a heart attack, please go to the ER. Don't go to urgent care. If you think you might have to be hospitalized, that's a much better place to be at an ER than an urgent care, because if you go to an urgent care, they think you need to be hospitalized, they will likely recommend calling an ambulance, and that could be an extra fee or something else that we wouldn't want to be put on you. So if you think that hospitalization is a possibility, the ER is a much better place for you to be.
Do I drive myself to the ER as I feel like I'm having a heart attack?
I wouldn't recommend it, no.
911?
If you feel like you're having a heart attack, 911 is a really good resource. Please call
take an
that.
aspirin.
Yes, take an aspirin. Would you like to add to this question?
Sure. Well, maybe not on all of this. I think maybe if there are questions afterwards, we can go through like maybe the right side. And though I wouldn't mind maybe throwing out 4Ms right now.
Yeah.
If that's all right, Brett.
Sure.
So if you all look at your handouts, you have a thing that is 4Ms. My life, my health, my goals, and my 4Ms.
It's a separate page.
And it's a separate page. The front just describes what the 4Ms are, and the back is a little question and answer you could do when you get home. But it's super important, it stands for what matters is the first M of the four, then medication, mind, mentation, dementia, depression, and then mobility. There's work done 50 years ago by the World Health Organization that showed that the health of a population is not related to medical issues. It's inverse to functionality. So mobility, having function, is more important in survival. It's been shown over the years, as is social risk factors like isolation, loneliness, transportation problems, food insecurity. All of those, yes, medical is important, but as a physician, I became humbled 40 years ago, becoming a geriatrician and understanding that medical is less important than everything else when you get right down to it. It's connectivity. So I encourage you to use, review the 4Ms. What's important about the 4Ms also, from a population and even a health care expense standpoint, is that when these 4Ms are utilized in one's planning for current and future care, is significant in maintaining life expectancy. So when you go in next time to see your physician, primary care specialist, have this filled out and educate them about the 4Ms. I encourage. I think my practice is probably one of the few in the state, along with the Sanford Center for Aging, that uses the 4Ms on a regular basis. Thanks.
So what would that look like if I'm going to go see my primary care physician or specialist? What would I write on this form?
Right.
To communicate with them?
Show the back. Thanks, Brett. The back page of this. What matters? And as it says, take a moment, think about who you are and what you are facing right now. What's most important for you? And an example, just in the last couple of weeks, had a woman diagnosed with breast cancer that has spread throughout her body. And her goal is not to have chemotherapy and radiation. It's to see her granddaughter graduate high school in June. So there's a good example of what matters. A 90-year-old, and I'm not being ageistic as a geriatrician. I am not ageistic. I'm soon to be 71, so I'm not ageistic. But what's really important is if someone is facing, having major heart surgery or lung surgery, it's determining, okay, what is more important to me, having this surgery or accomplishing something else? So medications are always important to have your medications reviewed every time you see your primary care physician, provider, specialist. With a health plan, whether it's Prominence, Senior Care Plus, Optum, AARP, they have pharmacists that can review your medications, and fewer is better. There's a saying in geriatrics, start low, go slow, and then the mind, staying active from a social perspective, picking up new hobbies. I'm a guitar player, and I've been playing since I was 13. But what I've done, I no longer do so much rock and roll from the 60s, but I've gotten more into country because it's working another part of my brain with guitar. And then mobility. So, what is important for you? Is it to be able to, get from, kitchen to bathroom to bedroom? Or is it to walk a quarter mile a day, get out to get your mail, those kinds of things? And so that's just some examples. And I think once we understand what's important to us, it helps direct how we want our care delivered. So
this really helps us communicate better with our primary care physician or a specialist, so they know what's on our mind versus just following their normal path.
Exactly.
Yeah. Okay. So who then really is responsible for our health and our health care? Is it our primary care physician specialist, or is it us? Are you there advocating for us, or do we need to advocate for ourselves?
Well, number one, it has to be you, the individual. and having that relationship. And I want when John Adams, President Adams, celebrated his 75th birthday, quote from him, he had a party and his physician was about 30 years his junior, and his physician kept bragging about John Adams being 75 years old. And John Adams said, I've got to set the record straight. I am 75. I have a little rheumatism, a little asthma, but I'm 75 because I seldom see my physician. So I think that's really, and there's a lot to be taken from that. It's that when you need to see a physician or someone in the healthcare field, fine. Though you need to take control and be as educated as possible. Therefore, you can utilize the system as well as one can. So
Dr. Sanford, what are some examples then of people who you see who are very good at advocating for themselves versus someone who perhaps is not, who perhaps doesn't even come to see you?
I think it goes a lot back to those 4 M's of what you really care about. Sometimes as physicians, especially specialists or other things, they get their list of what you need to do. Like they see your high cholesterol, you need to treat that. They see your diet, like they see your things and they're like, it needs to get better. It needs to get better. But it's important that that matches up with your goals. It's important that it matches up with what you want out of life and what your quality of life is. So it's hard for a lot of physicians to know what your goals are if you don't tell them your goals. Unfortunately, physicians can't read minds, and everyone has different goals. So somebody might want to live to 100. Somebody else might want to live till their granddaughter graduates, something like that. And if you want to live to 100, chemo might be the goal, but if you might not want to go through that and go through that quality of life. So it's very specific, and medicine is very specific to each patient, whereas one size does not fit all. And it's hard as doctors to know what size you are in the fact of what you want and what you need from us. So it's very important that you tell us what you want, and that you advocate for yourself in that sense. And if a doctor keeps telling you that to do something that you don't want to do, speak up. Let them know that you're not okay with that you want something different. And if you keep seeing that same doctor and they keep pushing that one thing on you, that one treatment or that one medication or something that you don't agree with, there are other doctors in town. There are other people that you can see. And it's okay if you don't fit with your doctor to try to find somebody else that can give you the best care for the best rest of your life, to give you the highest quality of life for the rest of your life.
So I'm not going to get a negative star against me and no doctor wants to see me.
Well, I have to say, Nevada is, especially Reno, is still the Wild West, and the Lone Ranger doesn't ride as much as they did in 1992 when I came, but they do still ride. So some physicians take questioning less favorably than others. Okay. And I think that's just how it is. And so I'll go back to what Dr. Sanford said earlier about NP, nurse practitioners and physician assistants. I've embraced NPs and PAs as colleagues since I happened to do a fellowship in 1986 through 88 back Long Island in New York, and because I went to medical school in New Jersey, even though I grew up in California. The thing about NPs and PAs is they're much better listeners. Thank you. They're just much better. And so I've always advocate, as long as there is collaboration, not supervision, but collaboration between an MD, DO with NPs and PAs, and they're communicating and they're working in concert for your well-being. It's fine seeing an NPPA, and they do listen better. They just have that knack. I find RNs, because it's an RN who becomes an NP. And most registered nurses spend 5 years or more as a registered nurse before they go into nurse practitioner school, which is another 2 years of intense training. So just a word on that.
And thank you for being delicate with the way you first. So just following up on that, the lady who's, dealing with cancer and it's obviously terminal and wants to see her daughter graduate, her granddaughter graduate. In that circumstance, would I be incorrect to say that there are some doctors who would be pushing to, through training to keep that person alive as long as possible, may not necessarily want to offer other alternatives. Their ego is, I'm going to save this person's life no matter what.
Right. And Brett, I'm not sure if it's only ego. It's that training, to become an oncologist, someone who treats cancer. You do 3 years of internal medicine residency, and then you do, 4 years potentially of fellowship, depending on where you go through oncology, but a minimum of 2. And it's after 4 years of medical school. So it's the difficulty with letting go, and feeling it's a failure. It's not that they're trying to just do this because they want to make money. It's hopefully that's not the case. It's that they just have trouble letting go. And so you'll find that I have found that as in my own career as a geriatrician, I've matured, if you will, in being able to listen more and supporting, because they're just in my fellowship. I had a professor that would always say, when you've come out a high-powered, I was chief resident, Rutgers Medical School, internal medicine, high-powered, training program into geriatric fellowship. Within about 6 months, I was really struggling. And this professor, Con Foley, said, Steve, you have to learn that success is not just getting someone through the intensive care unit off of a breathing machine back home. Success can be, listening and accomplishing what that individual wants in their life. And so it was like I needed to change my rheostat for what is success. Okay. Yeah. Old term, right? But so anyways.
So back to the 4 M's, one of them being what matters to each of us. It's individual.
Absolutely. And I'll just ask right now, before I forget, how many of you have durable power of attorneys for healthcare and finance? So probably half. Well, the other half need to talk with the ones that have it and get it done. My wife and I established our DPOAs for healthcare and finance 31 years, almost 31 years ago, when we turned 40, and review it every 5 years, at least.
Why is that so important?
Well, because it's part of what matters.
But why does it matter?
I'm sorry. Where it's so important is that if and when, and the time will come when we will not be able to speak for ourselves, and we want to make sure whoever is advocating for us truly understands. So we have 3 sons, soon to be 47, 44, and 40. And they all know, what we want. They get frustrated when we keep bringing up, now you do know what's in our durable power of attorney for healthcare and what it is for finance, but you want that because one, you want to make sure, personally, I want to make sure that my wishes are honored as best as possible. And probably more importantly, for those who are left behind, that they don't feel burdened with having to make decisions that might not have been what I wanted or my wife Joanne wanted. So I appreciate the question.
So could you just repeat the first part? I think you said something in the words of along the words of when it does happen or when something happens. We all know nothing's going to happen to us. This life will be over one day and it doesn't really matter. So what do you mean by when it happens?
Well, okay. So there could be an accident. I mean, it could be, in an automobile, motor vehicle accident, could be a heart attack that has caused one to lose ability to breathe on their own, maybe affected the brain, could be a stroke. So anything catastrophic. I mean, yes, we would all like to think that, it'll just end one day. My mom probably came the closest to that. I lost her August 29th of 2022. She was 95 years old, living out with us at our ranch. And she died on hospice. But up until we celebrated her 95th birthday, May 14th of 2022, down in Marin County. That's where we all grew up, my brothers and I, and had a tremendous party for her. And she was like the queen of the show, and so intact. I mean, cognitively, she never lost her abilities. But then from May, she accomplished her 95th birthday. My dad had been dead already for 12 years, and she just wanted to go. So moved up to the ranch and started declining, and then on to hospice. And no specific, it wasn't like she had underlying heart problems and things like that. She just was ready to go. So, not everyone goes that way, right? So, but it's to be prepared. And so, why do you have car insurance? Do you have car insurance because you expect tomorrow or today to have an car accident? No, you just want to be protected. So I see durable power of attorney for healthcare and for finance is just like getting car insurance.
Good analogy. Dr. Sanford, let's just change tact a little bit in terms of we have great systems here locally, but a lot of people want to know, when do our systems here not provide the healthcare that we need, that we might need to consider going somewhere else, if at all? Are there situations where we just can't be served here, and what might they look like or be? And where would we go if we were in that situation?
That's a great question. The great thing is that in the last 10 to 20 years, Reno has grown exponentially. And while that can be bad in some terms, it's really good for our medical care because we have a lot of specialists that we may not have had around here 10, 20, 30 years ago. So we have all of the main specialists, and there are places to go if your health is declining and you have a very specific heart condition. There are doctors in town that can, for the most part, manage it. But we don't have a large research hospital, so we don't have like tertiary care facilities. So there might be a time when, if you have a very specific heart condition or lung condition or a very specific kind of cancer, need a specific surgery, that you might have to leave town and go somewhere else. The good news is that often you will be set up with a specialist to start with, and the specialists tend to be very good at contacting their colleagues over in the Bay Area or Salt Lake City or Las Vegas or somewhere that does have bigger hospitals. And they often lead the charge with helping you find out how to seek care there. Again, that doesn't happen very often, but it can happen, and it's not unheard of. But it's happening much less, which is great.
Thank you. Do you have anything to add, Dr. Phillips?
I'll put on a different hat and give some actual experiences from a health plan perspective. So I was the founding medical director of Hometown Health Senior Care Plus in 1996. About 3 years ago, I came back independent, part-time as their medical director to help improve their geriatric delivery line. And so about 5% of the members of Senior Care Plus, I don't see them up on the board, and but Prominence is. So Prominence is just like Senior Care Plus, Medicare Advantage plan. About 5% of members are unable to be provided services in this community. And it's mainly around major cardiac, any kind of transplant activities, major pulmonary lung issues, some very complex neurological. They either go west on 80 or east to Salt Lake City. Now, for both Prominence, I can speak for Prominence and Senior Care Plus, the preference is not to go west. California is a very expensive state compared, and their quality is no better than Salt Lake City. University of Utah and Intermountain Healthcare are some of the best hospitals and service centers in the area. And so there's a lot of movement. As a fact, for both Prominence and Senior Care Plus, you go to Salt Lake, they give you a stipend, daily allowance for housing, for transportation, for all that, because of the cost savings and the quality is there. So, and I agree with Dr. Sanford where we don't have the research. And so certain treatments just are not available in our community. It's gotten better. I mean, 30 years ago, everyone wanted to go to UC Davis, and that was it. I mean, and they would go to Davis and then they'd come up here to live. So, yeah.
So going east is not a bad thing. It's a good thing.
I think it's actually a very good thing.
Going south, do we get sent south at all?
Well, going south,
Las Vegas?
no, Las Vegas, University Medical Center offers not the same as University of Utah, but there are services that are the health plan. So Senior Care Plus utilizes this at University Medical Center. If they can't provide the service, then it's on to University of Utah.
Okay, thank you.
Sure.
Do you have anything else you wanted to add, Dr. Sanford? On that one? Yeah. So I know we've mentioned the term geriatric. Can't even say it now. Help me, someone. Old people, yeah. Do I need to run out and find a geriatric doctor to help me? Or is a non-geriatric doctor, when do I need a geriatrician to be helping me?
Sure. Okay, so just a quick, gerontology is the study of aging. So that's like the Sanford Center for Aging and Dr. Peter Reed and others are gerontologists. They study the aging process. A geriatrician is just like pediatrician, and it's really fascinating. The field of pediatrics was created in 1907. The field of geriatrics was created in 1909, all in Europe. Well, pediatrics took off. Geriatrics didn't actually become a recognized training program or area until I was in my fellowship in geriatrics back in 1986 through 88. The first certifying exam for geriatrics in America was in 1988. So the question, does everyone have to go to a geriatrician? Hopefully not, because geriatricians are one, few in numbers, and two, are trained to take care of the frail. So what I mean by frail are those that have mobility issues, multiple chronic conditions, 4 or 5 chronic conditions, 9, 10, 12 chronic medications, chronic, cognitive problems, dementia, which represents about 7% of all Medicare eligible individuals in the United States. 7%. I have found through national research that I did for Medicare and Medicaid, over 100,000 Medicare members we cared for in what was called a social HMO, a SHMO. And that social HMO proved to the federal government that more than 90% of Medicare recipients are well cared for by internists, family medicine, nurse practitioners, physician assistants. Where a geriatrician comes in, for example, Sanford Center for Aging offers this tremendous comprehensive geriatric assessment clinic, very in-depth. A geriatrician, social worker, pharmacist. It's a 3 to 4 hour.
Oh, you've been cut off.
It's a 3 to 4 hour evaluation, and not everyone needs that kind of assessment, but certainly one with multiple, chronic conditions, like I mentioned, would benefit from it. So, yeah, so not everyone needs to see a geriatrician.
Thank you for clarifying that.
Sure.
So the next question I had was just regarding the differences between health systems and hospitals that we have here. We have some fantastic hospitals, and obviously there's differences between all, but are there any differences our attendees should know about? Why would I go to one over another, or does it not matter? Are there questions that I should ask that maybe are important to me, but are going to be different to someone else?
Well, I think that the quick answer is, I'll try to be quick, is all of the hospitals that say the new Sierra, Northern Nevada Sierra Medical Center, Renown Regional, St. Mary's are comparable. Some actually offer something different than the other, but in general, I think they're, aside from the trauma rating for Renown Regional, they're comparable. What ends up making the decision is really what is your insurance, right? So, you know, if you're on Prominence, well, you know, they don't have St. Mary's anymore. That was canceled, that contract with St. Mary's, in anticipation of the new hospital opening. So you now have the Sierra and Northern Nevada on the Hill in Sparks. If you have Hometown Health Senior Care Plus, well, then you have Renown Regional and South Meadows. For St. Mary's, you either have Medicare fee-for-service or the health plan alignment that is offered, you know, but very small in Northern Nevada, penetration-wise. So, but as far as the services, you know, I'm talking as medical director for Senior Care Plus, I'd say procedurally, so surgeries, mainly in the areas of urological, so bladder, kidney, and prostate. Probably St. Mary's has the only whiz-bang tool for treating prostate right now. So probably 2 to 3% of you know, Senior Care Plus members go to either St. Mary's or Northern Nevada because Renown doesn't have the service, or the equipment is broken. You know, it's down for a while, and so that'll happen too.
So that's where I might end up going east, perhaps.
Yes. Yeah. Well, you would go east when they just don't have the services at all. But if it's available for, I can speak for Senior Care Plus, and I believe it's the same with Prominence. If someone needs a certain service and it's available in the community, but it's at a competing hospital, it's still more prudent, at least for Medicare, because the hospital can't charge any more than what Medicare pays. So it's a very it's different for commercial health plans, you know, pre-Medicare health coverage. But if someone on Senior Care Plus needs to have whatever done and Renown cannot provide that service, if they go to St. Mary's in Northern Nevada, the health plan only pays what Medicare allows. So they can't be charged more. So
that's good to know. Well,
right. Yeah. So that, so there's, but your point about going east, you would go east, instead of west, young man, you'd go east, young woman, if the service isn't available.
So Dr. Sanford, let's talk about insurance, given that's what we've just kind of moved to. I'm trying to be diplomatic like Dr. Phillips. What role does insurance play in terms of the decisions about our healthcare, whether we are denied something, whether something's covered? What do we kind of need to know about that? Are you really in control, and whatever you say I need, I'm going to get? Or does the insurance company get involved in there? And then what do we do if we're not in agreement?
Yeah, I wish you were right in the fact that doctors were in control and we could pick exactly what medications and what procedures that we want. But unfortunately, insurance does exist. And while it has some really good things, sometimes they like to say that you shouldn't have this medication or you shouldn't have this procedure because it's too expensive or too new. And that can create some roadblocks to care and some delays in care. But I want you guys to not take no for an answer right away. So if you go to a pharmacy, your doctor just prescribed you a new medication that they said is going to be really good for you. You go to the pharmacy, you go to pick it up, and they say, oh, it'll be $900 a month or something crazy. It's not, unfortunately, that's not unheard of. If that happens to you, don't just go home and not take the medication and say like, oh, I don't know what to do. I'm just going to not treat that. Talk to your doctor, call your doctor to let them know that there was that roadblock. And there are things that your doctors can do. Prior authorization is the big thing. So oftentimes for new medications, for procedures, there needs to be a prior auth, or a PA is what the abbreviation is for that needs to be filled out. And having done multiple things in the past to try to treat this, there are certain ways that doctors have been trained and that the staff of medical centers have been trained to try to work with insurance to get things covered. If that isn't covered, there are often alternatives and things that we can do to try to get you care, even maybe without that very expensive thing. But if you do end up needing that, it is possible to not take no for an answer. You can call your insurance company and advocate for yourself. And the doctors can advocate for you as well. So my number one advice would be to don't just ignore it and say like, oh, I can't do this. Let your doctors know, and there are things that can be done.
So to follow up with that, on pharmacy, and this is really for those of you on Medicare Advantage plans, whether it's Senior Care Plus, Prominence, Optum, AARP, Alignment, Humana, in this market. They're the ones who will say no. Medicare fee for service is still truly just a free for all. And no one's going to have a check or balance. Now, if you're a part of an ACO like Renown's ACO or Northern Nevada's Silver State ACO, Accountable Care Organization, or now called ACO Reach for 2023, they may reach out to you and want to, try to reduce costs if possible with an alternative. I mean, if you have anyone has a need for a medication, it may not just be that medication that was prescribed. Often we fall victim as providers, prescribers, of ordering something that is super expensive, maybe the new thing on the block, and that's the most recent thing you read about, where there are less expensive alternatives. And so that a pharmacy with one of the health plans has what they call step therapy, formulary step therapy. So they like to see, before you go to the $900 a month medication, have you tried, you being the prescriber and the patient, the member, less expensive that are in the same drug class and have similar efficacy. Now, so that's for medication. For non-medication, so things like a procedure, whether it's surgical or diagnostic, again, criteria are applied. They're called Millman guidelines, MILLMAN, and Millman guidelines are what all health plans pretty much use across the country. It has pretty specific evidence-based, so it's scientifically grounded in determining whether someone meets the criteria. Now, if it's termed don't meet criteria, and so a request is denied, which is not a pleasant way of probably getting a letter that, what your doctor wants to do, we've denied. But again, don't stop there. There are 7 levels of appeal. A lot of health plans don't want to say, there are 7 levels of appeal. Well, there are, and your doctor, provider can exercise those appeals. The first 2 appeals go to the health plan. After that, they go to what's called an IRE, independent review exam, and it's a board of outside, specialists, whatever the request was that was denied, who review and then rule back to the health plan. If they rule in favor of the health plan, which quite honestly, most 3rd level appeals get denied or overturned by the IRE. But if they are upheld for the health plan, then you have 4 more ultimately going to a court, to a federal judge. So now, in all of my 30 years of being medical directors of Medicare health plans, HMOs, health maintenance organizations, I've never seen anything get above a 5. I've always kind of wanted to see what it would be to go to level 6 and 7, but maybe I don't. So you do not give up.
So how do we go about that process? Who do we talk to when we've been denied? Is it back to our specialist? Is
Well,
it calling up the insurance company? How do I?
Well, actually, it's in writing and it's a written appeal. Though, going back to what matters, if it matters enough to you and you have the confidence in what your provider is requesting, you can call member services and customer service, member service, and lodge an appeal. And they will do it over the phone. They have to. You can say, I'm so-and-so, this is my, Medicare number or my ID number for the health plan. This is my denial. Here's my letter. They can look it up in the system and say, I am appealing. So you can do it. And I always recommend, now this is speaking as a consumer, I have Medicare and I belong to one of the Medicare Advantage plans. You might think it's the one I work with, and actually it isn't, because the other one has better benefits. But I would recommend that you appeal and have your provider appeal at the same time.
Thank you. So just following up about plans, you said one plan has better benefits. I guess that's very personal in terms of what benefits each of us is looking for. So should we be looking and comparing plans? It sounds like that's what you and your wife have done. Work out what's important for you, which one would be the best.
Right. And so when I say better benefits, it's not just what they have, that they give you or charge you. It's who the providers are in that network. So I have not, I have not, seen a physician or been in a hospital for, I think, only one time since 1992. My wife has had some medical issues, and she's well. She's doing really well now. Thank you. But her providers are, in the network for a certain plan and not in the other. And so that really was what helped determine. I mean, I thought, well, I'll just go with Senior Care Plus because that's what I founded. And my wife was like, well, I'm not. I thought, well, so, you decide when to do battle and when not, right? So I thought for harmony, and also I like kind of the irony that of going with a different plan. We both went with the same plan.
She won.
Absolutely.
Yeah.
She normally does. So
that could be a situation where your healthcare provider, your doctor, your specialist have moved to an alternate system and you want to stay with them. Therefore, you would need to change your plan.
exactly. Yeah.
Okay.
Yeah.
Thank you. That's helpful. What have we not covered that we need to share with our audience today that they should know? One thing, because I know we could be here all day. There's probably
maybe we can go. Let's go back to so this sheet that has major health event after a major health event. I did a good job covering some of the before, and so after. Here again, it comes back to advocating. If you can advocate for yourself, do it. If you cannot, make sure whoever is your surrogate, your advocate, which is identified through the durable power of attorney for healthcare. For those of you who have not completed one, means you don't have an alternative agent identified who has, and I think one of the most frustrating things that occurs is someone's in the hospital and a loved one who really is committed to the well-being of their mom, dad, brother, sister, and there's not a durable power of attorney for healthcare, and therefore there's not any alternative agent to speak, and you're stopped. I mean, they just, that's always the first, besides HIPAA, which is ridiculous. We won't go there, or I'm happy to when it maybe later, but if you do not have a durable power of attorney for healthcare, then you won't have an advocate. So, and
Can I
after
just stop you there?
Yes.
Half the room put their hand up and didn't have one. So where do they go to get a durable power of attorney?
Well, you just go right online. You can pull off the forms for I think Sanford Center for Aging had some stuff out there. I thought about, and I'm sure you all have different resources. I mean, there are some very knowledgeable organizations here that can help direct that, but they're online. You can go to like Kinko's, stationary stores have these forms. The important thing is you want to get them. You don't have to have them notarized unless you are currently in the hospital or in a nursing facility. If you're in an institutional setting, then they have to be notarized. But if you have an attorney, it's, that you work with, it's always nice, you can do both durable power of attorney for healthcare and finance. It's not that costly. And again, it's that insurance of
Maybe
having
a will and a trust while you're at it. So one of our partners, Schultz Law Group.
Right.
I know people were.
Revocable trust. I mean, all those things that's really part of that whole finance component.
And what if I'm calling on behalf of my mum or dad wanting to lodge a claim because they were denied and they don't have the confidence to advocate for themselves? They want some help. What do I need in place? Can I pick up the phone and call the Medicare Advantage plan saying we're not happy, we want to file an appeal?
You can call and they're going to say, okay, we don't have on file that you are on, an alternative agent. So if you can provide that for us, then yes, we will talk to you. Or have your mom, dad, on the phone at the same time and say, I authorize Brett Janelle, to speak on my behalf. All right.
Thank you.
But you're welcome. But at the same time, I think if that is the situation, that just is further emphasis to get your DPOA for healthcare and finance completed and have them available. I don't see anyone, looking at the audience, I don't, see, probably the relevance of what's called the POLST. I don't know how many of you have seen this shocking pink form, POLST. So it's a provider order for life-sustaining treatment. It's been in Nevada since 2013. I think we finally got it through legislation. And that form is an actual order that has to be honored by hospitals, physicians, providers, ambulances, REMSA, all that, and which is different than a durable power of attorney for healthcare. Durable power of attorney for healthcare just states one's wishes. Where a POLST, the POLST, actually is an order, and it goes through things like, I want full care, I want only comfort care, I want no care. So everything from use of intravenous fluids, antibiotics, being on a ventilator, resuscitated, those kinds of things. Now that is recommended for someone who has, this sounds kind of cold, but a life expectancy of 3 years or less. And that's just what's in the regulation. And the POLST goes by different names around the country, but 38 states honor the POLST. So when one's traveling, to have that with you is important. So anyone who has a POLST, we recommend. I was the founder of the POLST board for the state of Nevada. We recommend that you keep it on your refrigerator or somewhere that's, with any of your important papers that we should have available in case something catastrophic happens.
So I would assume it would be a good thing with that durable power of attorney, power for health, that someone else knows about it and what's in it. So if I suddenly collapse on the floor, and my wife knows what my wishes are, whether do nothing or resuscitate, do everything.
Exactly. And the same with your children. And that's why my children get tired of hearing about it, but they all have copies. They have electronic. They know my wife's, all of her passcodes for the computer, which she won't give me, but but that's another story.
But that's a tough topic, though. It's one thing to have the document, it's something else to have a conversation with a loved one and explain what those wishes really mean. I really mean, don't do anything, just let me go. Because the children might have trouble with that if you haven't. It's one thing for them to read it, but I don't think that's really what Dad wanted.
Right. It is, and that's why something like the pulse is so different than the durable power of attorney for healthcare. Durable power of attorney for healthcare is, as I said, your wishes, and recognizing that for the pulse, you want an order, so no one, I mean, if someone comes upon you or you get taken to the hospital, you want that form available that, you know, you have such an illness that you want nothing done. And it's an order versus just a wish.
Thank you. Dr. Sanford, did you have anything you'd like to add before we open it up to questions? Thank you.
So I would kind of leave this off before questions with two kind of priorities of where to go from here. Other than the power of attorney is incredibly important, having those discussions. The first one is having a primary care doctor, kind of a home base where you feel comfortable, where you can really tell your wishes to, and that you can go through the 4 M's with and really talk about what matters to you. I think that's so important as a first step of what we're doing from here. And then the second one is going back to those 4 M's as well as mobility. Unfortunately, as we age, if we're not actively moving forward with our mobility, we tend to move backwards. So getting up and going to get the mail, trying to walk a quarter of a mile, that sort of a thing, really working towards that can really benefit your health for the rest of your life. So I would really, really recommend trying to keep that mobility up and doing as much walking as you can now.
And why is that so important, the mobility, to keep it up? Can't I just take a break for 6 months and then I'll get back to why is it, like when we're young, we can get away with that.
Right,
Okay, I'll
right.
skip the gym for a year and then I'll get back to it.
And
why is it different as we continue to age?
Yeah, unfortunately, as we age, if we're not gaining, we tend to be losing a little bit. So we can just go in the wrong direction more than we would like to. So it's really important to just keep pushing every day to kind of move forward. Of course, if you're feeling sick or if you have a cold or something, you can take a week off, but it's really important to really prioritize that.
Yeah, and there is some data, this goes back, 40, 50 years in physical medicine and rehabilitation, that 5 days of being bedridden in the hospital after an acute illness, 6 to 8 weeks for those who can recover to get back to baseline. It may even be 3 to 6 months. So to your point, Brett, just to take off and it's hard to get back there.
Thank you. So who's learned something today so far? Good, lots of hands. Hopefully everyone's got their hand up. I definitely have too. So thank you both for that so much. Do you think there are other people that would have benefited if they were here today in the room also? Yeah. I was wondering if you could all do me a huge favor and take out your yellow evaluation form. And at the very bottom, can you think of like one person that you can think of that would gain value coming to a topic like today or any of the other topics that we do each month? Just one person, other than your spouse who decided not to come today. One other person, maybe a neighbor, maybe someone at church, maybe a club you belong to. You think of one other person that would be benefited knowing about the great resources we have here in the area and the great service providers that we have by coming to these seminars. Yeah, just at the very bottom of the page, just one name. And then can I ask you, if you're comfortable, putting down a phone number? If you have their phone number, could you write their phone number? And the reason I ask that, if you're comfortable, we will reach out and we'll personally invite them to come along. And if you feel more comfortable inviting them to come along and in fact bringing them with you, that's great too. But if you can think of someone, we'll have our team just reach out and just a nice invite to come along next month and just try out one of the seminars. That'd help us greatly. So next month, our seminar topic is actually some resources. So we all have the 4 M's handout. So thank you so much, Dr. Phillips, Dr. Sanford. That is a great resource. We also have some books for those who like reading, and I'm sure you're both aware of at least one or more of these. And I like the first topic. I've got some good news and some bad news. You're old. Inevitable. Hopefully we all get to be old. And Tales, what to expect in your 60s, 70s, 80s, and beyond? Because that's a question we often get when we're helping people downsize. What does it look like in another 5 years, and another 5, and in 10 years, what does life look like? So just helping us to kind of understand what life looks like. The second one, how to avoid being a victim of the American healthcare system. So basically being an advocate, what to know, basically what Dr. Phillips and Dr. Sanford have shared with us today, but just in more detail because we only had 60 minutes. And then the last book I really like by a doctor whose name I can't pronounce. Thank you, Atul Gawande, Being Mortal. It is a fantastic book because he's a physician dealing with his aging parents. And just like Dr. Phillips and Sanford said, you've been trained to save lives, prolong lives, but just dealing with our mortality and when is enough enough? And he had to deal with that with his own parents. When is quality of life more important than living longer?
He's a colleague of mine. He's a neurosurgeon and very prominent neurosurgeon at Harvard. And he his parents, as Brett said, but what really I'm excited by when you read this book, you'll hear about a Felix Silverstone. Dr. Silverstone was one of my mentors in my geriatric fellowship, and at Jewish Institute for Geriatric Care, Long Island Jewish Hillside Medical Center. And he and his wife was suffering from dementia, and he and his wife relocated near children in Boston. And Dr. Gawande has the coolest description of this nail-biting experience being in a car with Dr. Silverstone driving and wondering, am I mortal? Really? So, but it is a great, it's a great book. I agree.
So I'll challenge someone to read it and come and tell me if they enjoyed it as much as I did between now and next month. You've got 4 weeks. Who attended our seminar back in January, Aging in the Best Place? And who has decided that they're never ever moving, had already had decided that, or have reconfirmed that they're never ever moving? That's good. That's how I feel too. So, however, as our two doctors have said, shit happens, stuff changes, events happen, and sometimes we do need to make a move for whatever reason, whether we choose to or not. But as they've both said, we need to advocate for ourselves, be educated, know what our options are. So next month is all about knowing about what are the different senior living options for those of us who aren't yet ready, which is most of us. But if we needed to be ready, what would our plan B be? So that's what we're going to talk about. And then in April, we're going to talk about the truth about driving after 80, strategies for staying behind the wheel, because we all want to maintain our independence. We want to drive as long as possible. So what are some of the things that we can do? And then how do we know when maybe it's no longer safe, but what can we do in the meantime? So do I have my two mic runners? Who's helping me on this side of the room today? And Lisa, you come up just very quickly because we're running out of time. Who you are and which organization you're with, Gina.
Gina Gary I'm an independent insurance broker representing Prominence here this year. And that's it.
Perfect.
Great
Thank you so
job.
much, Jen.
Yeah.
Gina's going to take this side of the room. So if you have a question, put your hand up and Gina will get the microphone over to you. And Lisa?
I'm Lisa Fleck with Neo Home Loans.
Well, that was really short. Okay, Lisa's going to take that side of the room. So let's start over here, Gina, back corner. And if it's for one of our specific doctors, just mention their name, or if it's general, they can just choose who's going to take it.
I have one comment and one question. First off, thank you. My mother and father need a geriatrician, so I came here because they were sick today, so I'm their advocate today. But being on the insurance world, just want to add one comment to your great explanation of hospital systems and insurance companies. Whether you're on an Advantage plan or not, go and you need the ER. Don't look at which plan covers your hospital. If you need the ER, go to whatever ER is closest to you in an emergency. Do not drive across town. I had one client drove across town because she thought she had to stay with that hospital system when she was having a heart attack. Go to whatever hospital is closest to you, please. They will pay for it wherever you go. Two, doctor, you said you review your power of attorney every 5 years. Why do you recommend? I have a power of attorney and I don't review it. It's been 10 years. What would be the benefits? Nothing if my same people would be my decision makers for me. So what would be the advantage of?
Why review our
Because you may change some of the things that your life changes, and maybe your power of attorney is do everything. and maybe you're now, because of changes in health, decision is, okay, yes, you can try to resuscitate me, you can try to bring me back, but I don't want to be on a ventilator. You know, and so it's those kinds of things. And then it's also the power of for finance. So I just think, and I'm probably a little older than you are, and so the average age of the folks we serve in geriatric specialty care of Nevada is 85. So and it's a house call, it's a home-based primary care practice. It's the largest in the state of Nevada, over 20 providers and 50 support staff. Going into the homes, assisted living, group home, private residence. And I agree with you, and I really appreciate you calling out with the emergency. There are laws, and it's not just for Medicare plans, but commercial health plans. If someone goes to an out-of-network emergency room for what is deemed a true emergency, and for the most part, emergency, it's required, then the health plan cannot deny coverage. So for a Medicare Advantage plan, though, if you end up being hospitalized in a non-network hospital, you likely will get your whole care there and then return home. If you're not on a Medicare Advantage plan, you're on a commercial plan, so maybe your children this would apply to, they may get transferred once they're stable into a network hospital. But that was a great point. I appreciate that.
So don't be reading your policy as you're having a heart attack, and don't be driving yourself to that emergency room. Good, thank you. Over this side, please.
Okay. Anti-aging is a specialty that's starting to come up, but a lot of their treatments are just not FDA approved. And so therefore, insurance won't cover that. I would just like your opinion about some of the anti-aging treatments, and do you think it'll ever surface and become a viable treatment that FDA might go for?
Sure. Okay. So I'll take this. It's and then
So this is like the
Dr.
fountain of youth. When is insurance going to pay for the fountain of youth?
yeah. Well, I can assure you that I'm a researcher as well as a clinician and advocate. Our lifespan is limited, even with no diseases, and this goes back to, gentleman's name is Leonard Hayflick, Hayflick from UC San Francisco, researcher, the Hayflick phenomenon. We know for a fact that our cells, so what makes up our body, have a finite number of replications. Once they can no longer replicate, then death occurs. Now, that's without any diseases that are cause, earlier death, if you will. Now, with anti-aging, there is nothing in the literature that has been randomized, controlled, head-to-head studies to show efficacy of any of the anti-aging, antioxidants. Now, I believe in vitamin C, taking antioxidants, but when it comes to growth hormones and testosterone and things like that, there is nothing in the literature. Matter of fact, I have treated 5 individuals who utilized growth hormone, testosterone, ended up with heart failure. So I just am not a supporter. So that's, and the literature doesn't support. So I don't really think, at least in my lifetime, there will be anything that's going to be identified that really works. You're welcome.
Over this side, Gina. Down here, Gina, if you wouldn't mind. And then while you're coming over, whoever you're in front of.
Well, I really think his statement was his Nana told him stay out of the sun. And that is so brilliant, because the sun causes free radicals. Burning breaks down cells. And so you get free radicals that can worsen, the aging process. So she was very right.
This was touched on just briefly, but what exactly is the difference between a physician's assistant, a practical nurse, and a registered nurse?
Yeah, that's a great question. So A registered nurse is somebody who goes to undergraduate and they get their nursing degree, and then they frequently work in hospitals. So typically the bedside nurses, you go to the ER, those nurses, you stay hospitalized. That is what a registered nurse is. And they work under a doctor, and they typically don't make their own decisions. A PA is a little bit of a different type of school. You're not a nurse before you become a PA. It's completely separate, and that's called physician assistant. And what that is that it is another healthcare provider that can prescribe medications, can do procedures, but they're under the supervision of a doctor. They work with a doctor. A little bit different from both of those is a nurse practitioner. And so that is somebody who's been a nurse. You have to go through nursing school. Oftentimes they are at the bedside for close to 5 years, and then they can go back to school to become somewhat similar to a physician assistant, where it's another 2 years of learning and working alongside doctors. And oftentimes they also work underneath doctors. It depends on the state where if they're able to prescribe medications without being overseen by a doctor. So there's just different levels of schooling and different levels of experience that go with all of those. And then MD and DO are very, very similar. Yeah. So that,
So to follow up with that, a registered nurse or an LPN, licensed practical nurse, they can assess, but they can't diagnose. And so it's a scope of practice. And if you can't diagnose, you can't prescribe. And so I always like to, in my small world, is we should all operate at the top of our scope of practice. I don't care what your profession is. And so nurses, the top of their scope, but they cannot assess. They cannot diagnose, they can assess. APRNs, PAs, they can assess and diagnose. And then a little history, because I'm sure history buffs here. The physician assistant program started at Duke University, 1962, with returning paramedics from Vietnam. So that was the beginning of the physician assistant program, and then it just took off across the country. The nurse practitioner training started in 1988 at University of Washington. So it's just really interesting, the phenomenon, and both of them created to utilize already available resources that could be put into a higher level of the healthcare system.
I want to see my mic runner. Over this side. Thank you, Lisa.
My sense is that physicians and medical professionals have been and continue to organize into medical groups, hospitals, etc. Are there still creatures out there that are independent physicians, and is there pros and cons to each of those critters?
I would say I was one of those creatures who remained independent until sold the practice, and I would likely still have the practice, though it was being run by my children, and they wanted to do other things. I mean, literally my kids since teenagers have been, making records, files, all the way to one being the CEO of the company. And so, but you're right. It's highly unlikely that we will have independent practitioners in the next 5, certainly 10 years. And part of it is just the way that this health systems have moved. I mean, for efficiencies, if you call that efficiencies, no, across the country. Yeah, across the country.
Thank you.
I want to thank you very much for your presentation today, both of you. It was very interesting. I used to be married to a physician, and I just about 5 years ago retired as an aging and disability services chief with the state of Nevada. So I love this organization and so forth. I just want to say that there is one thing that I have researched, even though I'm not a doctor, but I am aware of, and that is that anti-aging, there are avenues toward that. Neil Rousier down in California in Palm Springs has a practice where he focuses on that. And his is bioidentical hormone replacement therapy. It is the pharmaceutical drugs that replace estrogen, progesterone, testosterone and so forth that create all kinds of problems within the body because the body rejects that it's not bioidentical. And I've been on that kind of hormone replacement therapy for 15 years, and it's wonderful. And there's much, much experience in that field. And I hate to see people miss out on that.
Well, I appreciate that perspective. I'm not saying there's no role if someone is deficient in certain hormones. Okay, so if someone has, and you can do blood work. So and if someone is deficient in certain hormones, then replacement, because if you don't have the hormones that you need, hormones are those chemicals that are made in certain parts of the body, like thyroid hormone, insulin, estrogen, testosterone, and they're made in one part of the body and they have an effect at a distant site in the body. So if someone is truly deficient in, any hormone that they should have, okay? So the woman doesn't necessarily need testosterone. So there are some actually interesting discussions around that. But if you're deficient in a hormone and to have it replaced, I'm all for that.
Okay, I would add to that, you're right about that, because it's about deficiency. But the fact is, as people age, their hormones can back off slowly, and you can get to a point where your physician is not going to read it on a medical test. Everything for lab work is what is the average for this age group. And Dr. Rouzier takes people back to their 20s or 30s and what their energy level was. And lab work doesn't show the deficiency. So again.
Thank you. I really appreciate that different view, just so we can get around as many questions as we can. Yeah, and feel free to come up afterwards and discuss it further. Lisa, when you've taken Joe, there's a lady behind you who's been, could you get to her next? And then Gina, who's over here next? No hands up on this side. So let's go. That gentleman there, Gina, next.
Hello. Okay, I'm on. I want to ask about a difficult situation at times in changing doctors. And there's one specialty here in town that has sort of a monopoly on its specialty, and it's called Urology Nevada. I didn't like a doctor I was changed to after my original doctor was retired. And I say that as active voice, was retired. And I found him to be a very, very difficult person to work with. He wouldn't listen. He interrupted me when I spoke. So I tried to write him a letter and explain the situation. And that turned me into a bad person at Urology Nevada. You should see the 2 letters they have on their website about how patients are supposed to behave. There's nothing about how the doctor should behave. I asked to talk to the office manager. She never called me back. So I am now seeing a doctor 45 miles away, and he's a pretty good guy. And I would like to hear what you say, because it's like a conspiracy of silence as far as I'm concerned in this town about urology. I don't know if what you mentioned about St. Mary's and prostate care, which this has to do with, would be a solution.
So where should Joe go in this case, or any of us?
Well,
we're not happy.
Yeah, and it's not just Urology of Nevada. I mean, the GI market is pretty well locked up. I mean, you have 2, but one is dwindling rapidly. We're going to be down to just 1, it looks like. Neurology is pretty scarce. Rheumatology, but your point, I mean, not to be ignored, is correct, that there is this code. I mean, I remember if you were seeing one doctor in a practice, a specialist, and you wanted to see another, it wasn't allowed, right? I mean, just wasn't allowed. So, and from a health plan standpoint, we have members that have been blacklisted, if you will, by Urology of Nevada or other practices, specialty. Primary care don't see that, but by specialties or specialists that are now going to Carson, and we pay their transportation. we use Uber Medical. Just, it's an inconvenience, though it does exist. And so then to your question about St. Mary's, it's a certain procedure. It's called water ablation of the prostate. So instead of the old surgical way of, removing the prostate for men with large prostates, it's water ablation. It's less invasive and less traumatic. So, and St. Mary's is the only hospital that has that device. So that was what I was talking about. You're welcome.
Just, okay, yeah, go ahead. All right.
Hi, I have a very simple question here, I think. We are bombarded continually by TV about the memory drugs, Neuriva and Prevagen. Would you please say something about that?
Thank you for asking that question.
Yeah, happy to. Not, yeah. No. So they're just in this line of medications that appeared in the late 80s and 90s. And I don't remember if you recall Aricept. Aricept was the first drug, highly touted. That data was falsified, the research. I mean, it was really a horrific. Then you got things like memantine. Then you have Prevagen. Quite honestly, it's been a failure in trying to figure out how to replace the chemical that leads to dementia. And for just a little science, so the physiology behind this, we have a little thing in the brain, kind of looks like a seahorse. It's called the hippocampus. And the hippocampus creates acetylcholine, and it's an neurotransmitter. So it makes nerve cells communicate. Individuals with Alzheimer's, the hippocampus fades away, if you will, and they can't make that chemical, acetylcholine. So all of these drugs like Aricept, memantine a little differently, but still and Prevagen are to enhance whatever amount of acetylcholine is still in one's brain. Never been effective. I mean, it just really, and America keeps with big pharmaceutical companies pushing. In Europe, you can't get these drugs most of the time unless you're going to pay, essentially in the black market, because it's been shown that they just are not effective. The likely solution will be lifestyle. So if you don't live a Mediterranean diet or DASH, the hypertension diet, then you should start doing it. Exercising. We can't do anything about it genetics. I mean, if we had genetic predisposition, and there is for certain forms of dementia, but it's ultimately, I think, it's going to be a vaccine. And there is some work being done, National Institute of Health and Aging, that is showing some promise for a vaccine. But yeah, I think it's just, now to be fair, with Aricept and memantine, the data does show that you might reduce need for, in one of the sessions is going to be about alternative living solutions, you might reduce by 6 to 12 months the need to move out of one's home into assisted living or a group home. So there is some value there. But after someone's been on these medications, it's been more than 12 months, my recommendation always to family is it's time to taper. So half the dose for 2 weeks, half again for 2 weeks, and then stop it. And once they're educated about the reasoning behind it, they seem to accept that.
Thank you.
The reasoning behind stopping the medication is because it's not effective anymore after 12 months.
Thank you. You've been very informative. My question is about you were talking about prescription drugs and where they were denied and you had an appeal. Does that appeal process work for the cost of the drugs? Do you
Uh,
know?
No, no. Now the cost will be whatever your copay is for that drug. So if it's a generic drug, you probably would never have it denied. But if it's a brand drug, then you would pay whatever your brand copay. Now, if it's a specialty drug, you will then it's a complicated formula. It's the AWP, average wholesale price, times a percentage is what you're going to have to pay as your copay. It's not just a general brand copay. So it gets pretty complicated, but you cannot appeal the cost, at least not yet.
Okay, thank you.
You're welcome.
Do we have any other questions before we wrap up? We've got time for one more question. Over here. Maybe two if they're quick questions.
Yes, this too was touched on earlier, or actually in the handout.
Can you just hold the microphone just a little
Sorry,
closer? Thank you.
about hospitalists. Now, once one is in the hospital, one has a hospitalist assigned. It's my understanding that this means that then one can have no further contact with one's primary care physician. Is that true? Can that possibly be true?
So that's a great question. Years ago, it was that the primary care physician would come into the hospitals and be the hospitalist. And that has changed as hospital care has become more specific and pretty intense, so that there will be a hospitalist that sees anywhere from 15 to 18 to 20 patients in a day, and they round on those patients and they're there for the patient if anything happens in the hospital. The question is, what role can the primary care doctor have in that situation? And oftentimes, if your primary care doctor would like to, and they know that you're in the hospital and they do this, some primary care doctors will visit their patients while they're in the hospital. The role of, if they can dictate care, is very different. They can asked to talk to the hospitalist, but the hospitalist is in charge of the care while they're there. And they are the one in charge. But most hospitalists would probably be all right with having a quick conversation. I mean, they're very busy. Everyone's very busy, but would probably be open to having a conversation or with looking over records that they've had or something like that. But the hospitalist is the one the one in charge these days. Yeah.
Thank you. Do we have a quick question over here?
Yes. I feel a bit naive, but I'm looking at all of these healthcare plans and I don't see anything about TRICARE.
Well, okay, so TRICARE is Medicare fee for service for retired veterans, and it is the gold standard of health coverage. In the early 80s, Congress passed legislation for TRICARE. It wasn't until 1996-7 that they finally funded TRICARE, but still, I mean, they finally were able to fund it. And I remember it vividly because in my practice, I knew everyone who was a veteran. That was one of our intakes. At that time it was Geriatric Care of Nevada. I had to think about GCN, Geriatric Care of Nevada. And once that got funded, we sent out letters to all of our veteran patients, letting them know, get rid of your secondary, contact the VA, get on TRICARE. It's the best coverage, though that it's deserved because these are retirees from the military, 20 plus years. And I was at one time chief of medicine of the Veterans Home of California in Yountville, and had the honor of serving 1,750 veterans on that 600-acre parcel in Yountville, Napa Valley. So yes, but I think we don't see it because TRICARE doesn't advertise. From a standpoint, they're not like a health plan. They're the federal government's insurance for those who served and retired.
Thank you. So just before we wrap up, can I just ask everyone to complete the yellow evaluation form? And if you would like to attend the seminar next month, just indicate on there and we'll get you pre-registered.